First and foremost, I do want to state that I have no financial disclosures or any conflict of interest. Thank you everyone for joining. We'll be talking about the spectrum of pulmonary complications in COVID-19, and we'll be discussing the airway, alveolar, and vascular compromise in the disease. Over the next 45 minutes or so, we'll discuss the pathophysiology and pulmonary manifestations of COVID-19 in the lungs. We'll also talk about COVID-19 outcomes in patients with underlying lung diseases. We'll touch upon readmissions in COVID-19 and finish off with post-COVID-19 syndrome. I do want to say that by no means did I attempt to have a very comprehensive review on how SARS-CoV-2 infects the human cells. I just wanted to touch upon the basics to set the stage for the rest of the talk. So as everyone knows by now, the spike protein on SARS-CoV-2 allows the virus to attach itself to ACE2 receptors on human host cells. Now the type 2 transmembrane serine protease is very important. It's on the host cell. What it does is it cleaves the ACE2 receptor and it activates the spike protein. And this action allows the virion to enter into human host cells through endocytosis. It releases its genetic material, which then utilizes cell machinery to replicate. Hundreds of virions are formed and they then get released to in turn go and infect the neighboring cells. Now, ACE2 receptors are located on the nasal and bronchial epithelial cells, as well as type 1 and type 2 alveolar pneumocytes. Now, once the virus infects these cells, there is an inflammatory response. Innate and adaptive immunity gets triggered. Humoral and cell-mediated immunity causes inflammation of a lot of monocytes, neutrophils, lymphocytes. This then causes release of cytokines, namely TNF-alpha, IL-1, and IL-6. Now, TNF-alpha, IL-1, IL-6 have been shown to be associated with severe COVID-19 and ICU admissions. Now, once the early stage happens, in the next stage, as more and more virus replicates and the inflammatory response increases, the epithelial endothelial barrier is compromised. The virus then enters the vasculature, is able to infect the capillary endothelial cells, which have ACE2 receptors, and then trigger an exponential rise in inflammation. There is influx of cells, there is thickened interstitium, pulmonary edema, diffuse alveolar damage, and hyaline membrane formation. And all these are classic findings of ARDS. Once the cells get access to the vasculature and there is endothelitis, there is triggering of the coagulation cascade, which results in thrombus formation. It could be something it could be local thrombus formation, or it could extend to systemic disseminated intravascular coagulation. This results in spread of the virus, systemic inflammation, sepsis, organ dysfunction, and multi-organ failure. Now, the CT scan in the early stage of the infection shows bilateral, peripheral, patchy ground glass opacities. The corresponding histo findings include inflammatory response, infiltration of the interstitium and the alveoli with monocytes, specifically lymphocytes. Now, as the inflammation progresses, we see development of consolidation. There is fibrosis and alveolar airway dilatation or bronchiectasis. The corresponding histo findings would then be diffuse alveolar damage, hyaline membrane formation, thickened interstitium, infiltration with cells, as well as microthrombi, which can be seen in just regular sepsis because of endothelial dysfunction and systemic inflammation, but also in COVID-19 because of the presence of ACE2 receptors in the endothelium. Now, there are several manifestations of COVID-19 in the lung, and I think the most common ones that we talk about are COVID-19 pneumonia and ARDS, but one should recognize that pulmonary embolism, pulmonary hypertension, pneumothorax, and pneumomediastinum and pulmonary fibrosis and bronchiectasis can all occur. In about 80% of the patients with COVID-19, the infection tends to be mild or moderate. 20% develop hypoxic respiratory failure, and about 5% of those 20% land up needing ICU admission and have poor outcomes. All right, so I'm going to talk a little bit about ARDS. The ARDS management, ARDS COVID-19 probably warrants a talk on its own, but I know that questions would come up, so I sort of did want to address it a little bit. This is not, again, a very comprehensive review of the literature of ARDS management. This is one of the papers that got a lot of press at the peak of the pandemic, because what happened at that time is, as more and more cases were seen, it became clear that there were a lot of patients who had severe hypoxemia, but at the same time appeared comfortable, and the lung compliance or the respiratory mechanics showed that the lung compliance was good. This is not very typical of ARDS, right? Because in acute respiratory distress syndrome, there is pulmonary edema, the lung compliance tends to be poor, and patients don't tend to be PEEP responsive. Now, I'll explain a little bit what this all means, but first let's talk about what potentially happens, right? So COVID-19 can cause sepsis and distributive shock or vasoplagia. This results in VQ mismatch, which can then cause hypoxemia, increased in the respiratory drive. There is increased work of breathing. There's development of high transpulmonary pressures, which results in stretch-induced lung injury, which in turn can cause pulmonary edema, a drop in the compliance of the lung, and the classic baby lung physiology, which basically means that the lung is not well aerated. Baby lung physiology eventually will again cause worsening hypoxemia, and this is a vicious cycle. The Willy vortex is what it's referred as. Now, if you think about the stages, in the initial stage when there is vasoplagia and hypoxia, VQ mismatch, one can imagine that the lung compliance is going to be good because it has no pulmonary edema. Before stretch-induced lung injury sets in, the lung compliance potentially is good. And this is what Garatoni and group describe as type L phenotype, where the compliance is high, and because the compliance is high, the lung is well aerated, and PEEP, or positive end expiratory pressure, will not necessarily improve oxygenation. Now, PEEP is the pressure at the end of expiration, which allows the alveoli to remain open. And it also helps to recruit collapsed alveoli. Now, in lungs that are compliant, there aren't a lot of collapsed alveoli, which is a reason why we don't expect those lungs to be responsive to PEEP. Now, in type H is after stretch-induced lung injury happens, because there is pulmonary edema, there is a drop in compliance, the lung is not very well aerated, which results in a lung that is more responsive to PEEP. Now, this all makes sense physiologically. This is exactly what we would expect. Now, the recommendations of the group was, when hypoxia sets in, the goal should be to prevent increasing the respiratory drive or the work of breathing, to prevent the rise in transpulmonary pressures, which could in turn cause stretch-induced lung injuries. So they recommend instituting non-invasive support early to support respiration. Now, if that helps the patients and oxygenation improves, then it's great. But if it doesn't, then they recommend early intubation, followed by a low PEEP and high tidal volume strategy. We'll discuss this in the next few slides. For the H phenotype, they recommend following the classic ARDS protocol, which is basically lung protective ventilation, that is tidal volumes in the 4 to 8 cc's per kg ideal body weight, and also to institute high PEEP, which can be titrated based on FiO2 requirements. Proning, ECMO, neuromuscular blockade would all be measures that can be instituted in the type H compliance. Now, what I wanted to point, this is all fine. What I wanted to point out about what the evidence is with respect to ARDS and what we know in the non-COVID setting, because it will help understand a little bit in terms of the management in these patients. So this is the original paper that showed that low tidal volume ventilation is helpful in patients with ARDS. It is considered to be lung protective. So 861 patients were randomized to receive 6 cc's per kg ideal body weight tidal volume versus 12 cc's per kg ideal body weight. Now, one has to understand that in this particular study, there were other parameters that were set, and the tidal volumes were adjusted based on these target parameters. So the goal plateau pressure should be less than 30. PEEP was adjusted to maintain O2 sats between 88 to 95%, or PaO2 of 55 to 80%. And the pH was adjusted to 7.30 to 7.45. If you look at the protocol in this study, they do mention that depending upon the patient's respiratory mechanics, the tidal volumes, so if the respiratory rate is too fast or there is a drop in the minute ventilation, we need to increase the respiratory rate further, then you can increase the tidal volumes up to 8 cc's. 6 cc's was what eventually they found was the average in the study when they analyzed the results. But the protocol does say that you can go all the way up to 8 cc's. Now, what they found in this study is that patients who received, the study was stopped early because in the interim analysis, it became clear that there was a mortality benefit. What they found is that the group that received low tidal volumes, the mortality was 31%, mortality was 31%, and the group that received traditional tidal volumes or high tidal volumes had a mortality rate of 39%. This was a significant difference with a p-value of 0.007. They also found that the number of ventilator-free days and the number of days without failure of non-pulmonary organs or systems was higher in the group that received low tidal volumes as compared to the group that received traditional tidal volumes. It's important to note that there was no difference in the prevalence of barotrauma between the two groups. So this was good. Now, what they looked at, or what they had, because they were wondering in terms of lung compliance. Now, if the compliance of the lung is good, does it matter whether we give low tidal volume or high tidal volume? Because technically, if the compliance is good, the risk of stretch-induced lung injury shouldn't be that high. So they had static compliance measures from a day before randomization happened. And when they looked at the interaction of the study group with the quartiles of static compliance with respect to death, they did not find a significant result. The p-value was 0.49. So they concluded that the compliance didn't matter. Whether the compliance was good or not, low tidal volume was beneficial with respect to mortality. But if you look at this graph closely, if you look at the high quartile group, the highest quartile group rather, the mortality difference seems to go. You can see a clear difference in the previous groups, but in this group, it vanishes. So the authors did follow up with another paper on this, and they looked at plateau pressures. Now, plateau pressures are end inspiratory pressures. They are also a measure of lung compliance. They are inversely related with lung compliance. So basically, high plateau pressures mean low lung compliance. Now, when they looked at this, they felt that the plateau pressures were probably a better measurement compared to static compliance, primarily because static compliance was measured before randomization happened. And all the patients, for the most part, received high tidal volumes because that was the standard of care at that time. And high tidal volumes could cause falsely elevated compliance measures. Now, when they looked at plateau pressures and they looked at the interaction p-value, the p-value was still not significant. It was greater than 0.23. So they concluded that, again, it didn't matter what the lung compliance or the plateau pressures were, as long as the plateau pressures were less than 30. We know from other studies that a plateau pressure of over than 32 is associated with higher mortality in patients with ARDS. One thing that I do want to point out with this slide is if you look at the quartiles of static compliance or the quartiles of plateau pressure, there is a wide variability. There are patients who have low compliance and high compliance in this group of ARDS. So it is in a way a very heterogeneous group. And not all patients with ARDS need to have low compliance. And this is what has been reported in multiple cohorts of ARDS. Now, this paper was the original paper that was published in New England Journal of Medicine, where they looked at the benefits of low versus high PEEP strategy in ARDS. And they recruited 549 patients. I do want to point out that all of them received low tidal volume ventilation. And the PEEP was titrated based on the current ARDS-NET protocol. I have it up here on the slide for your reference. And they found that low versus high PEEP did not offer any benefit in terms of mortality, in terms of ventilator-free days, in terms of barotrauma, or in terms of number of days without failure of circulatory, coagulation, hepatic, and renal organ dysfunction. So this is what was the original study. There have been a few meta-analyses that have been published since. Now, this one was published in JAMA in 2010, where they combined the data from 3 large randomized control trials. That's Alveolar, Express, and LOVES. The N, or the sample size, was 2,299. ARDS here was defined as a P/F ratio of less than 200. And everybody received lung protective ventilation, with the median value being around 6.2. What they found is that in all patients, in these 3, before I get there, I should point out that the reason why we have patients with ARDS and without ARDS here is the recruitment, the inclusion criteria for the patients in terms of P/F ratios was slightly different between the 3 randomized control trials. One recruited less than 250, one was less than 300, and the other one was less than 200. So the patients were re-stratified, and everybody with a P/F ratio of less than 200 were included in the ARDS group, and patients who had P/F ratio between 200 and 300 were included in the non-ARDS group. So now coming to the results, what they found is that in all patients, a high PEEP strategy was not associated with significant mortality benefit compared to low PEEP strategy. But they did find that the patients had, patients in the ICU had a mortality benefit with the high PEEP strategy. Now, when you look specifically at the group that had ARDS, patients in the high PEEP strategy group had a 10% reduction in mortality in the hospital. This was a significant result, and also had a 15% mortality reduction in the ICU. This was also a significant result. Now, what's interesting is if you look at the group without ARDS, high PEEP, so the patients without ARDS were the patients who had a P/F ratio between 200 to 300. And high PEEP strategy showed a trend towards higher mortality compared to the low PEEP strategy. Now, I do want to point out that in the group that had ARDS, it was likely a heterogeneous group where lung compliance was widely variable and included patients with low as well as high lung compliance. Now, in 2017, there was another meta-analysis that was published. This included patients from 6 randomized control trials, which looked at high PEEP versus low PEEP. And N was 1275, and the results, it showed that high PEEP did not have any effect on mortality compared to low PEEP. Now, again, all these patients received low tidal volume ventilation. Now, when they looked at the numbers and from two studies where patients received low PEEP but had high tidal volumes, and they compared the outcomes in that group with high PEEP and low tidal volume strategy, they found that there was actually a higher mortality associated with the high tidal volume and low PEEP strategy. But it was a small, it was only two studies that were included. There was not a lot of detail in the paper in terms of the analysis and the actual numbers, so I didn't put it up here. I don't think it was conclusive. It wasn't enough evidence to make any changes in the guidelines per se. In just talking about these three studies, I want to say that ARDS research is very difficult. The standard of care has changed over time. The definitions have changed over time. The current Berlin definition just uses P to F ratio to define acute respiratory distress syndrome. The etiologies can be very variable, as well as the time frame has to be, the whole idea behind cardiogenic edema has been removed, in the sense that if patients can have cardiogenic edema, but if the hypoxia is out of proportion to that explained by cardiogenic edema, then the patients can be diagnosed as having acute respiratory distress syndrome. At the end of the day, I think the optimal PEEP measure or the optimal method of PEEP titration is not yet known, and we can definitively not say that this is a good strategy in terms of managing patients with ARDS. All right, let's talk about other conditions now. So I wanted to talk about pulmonary embolism in COVID-19. Now, this was a cross-sectional study which included 107 COVID-19 ICU admissions. This paper was published from a group in Italy, and they found that 22 of the 107 patients, so 21%, had pulmonary embolism. Now, they wanted to see if COVID-19 was an independent risk factor for PE or not. So what they did is, in order to show that, they compared the prevalence of PEs in a general ICU cohort from the same duration of time in 2019. And they also compared the prevalence in all influenza patients admitted to the ICU in the whole of 2019. And as you can see, the prevalence of PE in the general ICU historical cohort was 6.1, in the influenza cohort was 7.5, and the COVID-19 cohort was much higher at 20.6%. Now, if you look closely, the number of ETPAs performed to diagnose PEs was also very high in the COVID-19 group. But they concluded that the reason for CTPAs was done based on the suspicion for PE when hypoxia was out of proportion to what was visible on the chest x-rays. And so they didn't think that that was solely the responsible reason for higher prevalence of PEs in the COVID-19 cohort. Now, patients, I do want to point out, patients in the COVID-19 cohort were actually less sick when you look at the SOFA scores and the SAPS-2 scores, which are the mortality prediction scores or the severity of illness scores. And patients with COVID-19 actually were more likely to have ARDS compared to the general ICU historical cohort and the influenza historical cohort. The other thing that the interesting thing that the patients noted was that the DVT associated with PE was not high in the COVID-19 cohort. As you can see, it was 58.3% in the general ICU cohort, 33.4% in the influenza cohort, and only 13% in the COVID-19 cohort. And the authors do suggest that maybe this is not an embolic phenomenon, and this is more a thrombotic phenomenon where there is capillary endothelial injury and activation of the coagulation cascade, formation of thrombi. Now, after that, let's talk about pulmonary hypertension in COVID-19. Now, this was a study, it was a cross-sectional study of hospitalized COVID-19 patients. The sample size was around 200. The chart review was done to look at the prevalence of pulmonary hypertension and right ventricular dysfunction in the cohort, which was assessed by transthoracic echocardiograms. 24 of the 200 patients, that is 12%, had pulmonary hypertension, and 29 of 200 patients, that is 14%, had right ventricular dysfunction. Now, patients who had pulmonary hypertension were older. They were more likely to have diabetes, hypertension, atrial fibrillation or atrial flutter, prior heart failure diagnosis, or cardiomyopathy history. It's also interesting to note that the patients who had pulmonary hypertension were also more likely to have COPD. Now, when you look at patients who had right ventricular dysfunction, mostly it included patients who had some sort of a cardiac history. So prior MI, prior CABG, prior valve intervention, arrhythmias, heart failure, or cardiomyopathy was associated with the presence of right ventricular dysfunction. Now, when you look at the mortality in patients who had pulmonary hypertension versus who did not, there was significant difference. Pulmonary hypertension was associated with a lot of parameters of severe COVID-19, such as lymphopenia, thrombocytopenia, elevated CRP, D-dimer, IL-6 levels, etc. All of these are markers of severe COVID-19, irrespective of the comorbidity or presentation. One thing that they did notice, that right ventricular dysfunction did not seem to be associated with higher all-cause death or ICU admission. Now, there are several reasons why patients can have pulmonary hypertension at COVID-19, right? There's hypoxia, there is ARDS, pulmonary thrombosis, pulmonary embolism, that can all cause pulmonary hypertension, as well as cardiac dysfunction, actually. All right, now, people have wondered if there is a higher prevalence of pneumothorax or pneumomediastinum in COVID-19 patients, because when we were taking care of these patients in the hospital, we saw a lot of cases. Now, this paper looked at that. What they did is they did a retrospective chart review study. They found that pneumothorax occurred in 60 hospitalized COVID-19 patients. And when they assess the incidence, it was about 1%. Now, this was much higher than what would be expected in the general population for the same number of people. So it did look like the prevalence was higher and maybe associated with COVID-19, but still the prevalence was in general low. Pneumomediastinum was present in 11 patients. That's all that they had to report because it was a very small number. Pneumothorax was seen more in patients who were over 50 years of age, in men who were on mechanical ventilation, had hypertension and hyperlipidemia as comorbidities, who were never smokers, surprisingly, and with no underlying lung disease. There was no difference in mortality, in the 28-day mortality when compared in COVID-19 28-day mortality when compared to the national COVID-19 mortality, the national average of COVID-19 mortality. When they stratified the data based on sex, age, need for mechanical ventilation, and acidosis, they found that age, like patients with COVID-19 and pneumothorax and who were older than 70 years were more likely to die compared to patients who were less than 70 years. They also found that patients with COVID-19 and pneumothorax who were more acidotic were more likely to die compared to those who were not acidotic. These two were the only significant results. There's no clear explanation as to what the association of age and acidosis would be with pneumothorax. And the authors eventually concluded that maybe these are just markers of severe COVID-19, severe disease, or just markers of increased risk for COVID-19 unfavorable outcomes. All right, now let's come to COVID-19 outcomes in patients with underlying lung diseases. Now, why would we expect these patients to have better or worse outcomes? Well, for the most part, these patients have poor lung reserve. But there's also another potential explanation, that is the ACE2 levels in the lung tissue in patients with underlying lung disease. So let's talk about ACE2 levels in patients with asthma. Now, this was a study that was done using samples from patients recruited to the Severe Asthma Research Program, or the SARP-3 program. And they looked at the ACE2 gene expression and the type 2 transmembrane serine protease gene expression in sputum cells, and compared the levels in asthmatics versus healthy controls. What they found is that the expression of ACE2 and type 2 transmembrane serine protease levels was not significantly different from that of healthy cohorts. What this basically means is that asthma patients likely are not at a higher risk, or rather the interpretation of this, I shouldn't say that they're not at a higher risk. The interpretation of this would be that asthma patients may not necessarily be at a higher risk for poorer outcomes in COVID-19, because the ACE2 receptor levels, the portal of entry of the virus, was not was similar to the national or the general population. Now, when they looked at the asthma patients a little bit closely, they found that the levels in asthma patients who were men, who were African American, and who had a history of diabetes were much higher than asthma patients who didn't have these comorbidities. So the authors did suggest that maybe even though asthma may not necessarily be an increased risk factor or a risk factor, patients with asthma and these comorbidities may be. Now, let's talk about what we do about ACE2 levels in patients with COPD. Now, this was a study where the ACE2 mRNA expression was looked at in lung tissue and compared in lung tissue of COPD patients and compared to controls. If you look at the graph on the left, the ACE2 levels in COPD patients was significantly higher compared to those of controls. The p-value was 0.003. And if you look at the levels in the asthma or airway COPD overlap group, it was not significantly different from either the controls or the COPD patients. And the thought was that this group is a little heterogeneous in the sense that it could have asthma patients, the true asthma patients who wouldn't necessarily have elevated ACE levels, but it could also have COPD patients who are either don't have very severe disease, who are not smokers, etc. And that's why the ACE levels may not be higher than the general population. Right. And if you look at the graph on the right, it shows the ACE2 mRNA expression it compares the ACE2 mRNA expression in patients with no obstructive airway disease and no inhaled corticosteroid use with patients with obstructive airway disease, no ICS use, and patients with obstructive airway disease and ICS use. Now, what they found is that patients who had obstructive airway disease but were not using ICS had significantly elevated ACE2 gene expression compared to those without obstructive airway disease and with no ICS use. There was no significant difference in the ACE2 levels in patients with obstructive airway disease who used or did not use ICS use. Now, why is this important? They looked at this because, and we'll discuss this in the coming slides, ICS use has been associated with decrease in ACE2 receptors in the airways. Now, this is probably why in this particular graph, we find that the levels of ACE2 expression was higher in patients who did not use inhaled corticosteroids as compared to those who used inhaled corticosteroids. And that is all that they wanted to conclude with this paper. Now, this is a paper that looked at ACE2 levels in patients with atopic asthma. Now, the levels of ACE2 expression were measured in nasal epithelial cells that were done in children at the age of 11. These children were recruited into the urban environment and childhood asthma cohort. The sample size was about 318. All these children had diagnosis of asthma, or rather, at the age of 10, there was a clear decision made in terms of whether the children had asthma or not. And when they looked at the ACE2 gene expression in patients with asthma and without asthma, it looked like asthma patients had similar to those without asthma. But irrespective of asthma diagnosis, allergen sensitization was associated with lower ACE2 levels, which basically means that patients who have atopic asthma likely have a lower risk for COPD, for COVID-19 or COVID-19, severe COVID-19 outcomes. And they also found a dose response in terms of IgE sensitization. The higher the IgE sensitization, the lower the ACE2 gene expression was noted. So this is, I have a couple of slides discussing ACE2 levels and its association with inhaled corticosteroids. Now, coming back to the severe asthma research program, patients who, the ACE2 levels in patients who were on inhaled corticosteroids was compared to those who were not on inhaled corticosteroids. And as you can see, there is actually a dose response. The higher the dose of the inhaled corticosteroid, the lower was the ACE2 gene expression. Similarly, the results were noted in when the type 2 transmembrane serine protease levels were measured. Now, they used ICAM receptors as a control. Now, ICAM is the receptor for rhinovirus. And as you can see, there was no difference in the ICAM gene expression with the dosage of inhaled corticosteroids. The other thing what this group did is they measured baseline ACE2 gene expression in a small group of patients. These patients were given IV triamcinolone, IM triamcinolone, and then the ACE2 levels were measured in the nasal epithelial cells 2 weeks after the steroid dose was given. And what they found is there was no difference in the ACE2 or the TMPRSS2 gene expression pre and post systemic corticosteroid. Now, there's a little bit more information that we have in terms of what inhaled corticosteroids can do with viral replication. That is, what the effects can be directly on SARS-CoV-2. This is a paper that was published by a group in Japan who looked at several steroids and their effect on viral replication. The human epithelial cells were pre-treated with these steroids. Some of them are inhaled. The commonly used ones are fluticasone, mometasone, and cyclosinide. And the systemic ones are prednisolone, cortisone, and dexamethasone. The human epithelial cells were pre-treated with the steroids. And then they were infected with SARS-CoV-2. And what they found is viral replication was suppressed significantly in the mometasone cell culture, as well as the cyclosinide cell culture. What they also found that the efficacy of viral suppression was actually very similar to that of lopinavir. So maybe these two agents have a direct viral toxicity. They did go ahead and try to find a mechanism, and they found some changes in the amino acids in the viruses that may make it susceptible to these steroids. But I don't want to go too much into that detail because that was not the focus of, that was not the point of the slide. All right, now this was a very interesting paper. This group basically showed that in acute lung injury, so this was not related to COVID-19 or SARS-CoV-2 or SARS as a matter of fact. What they showed is that acute lung injury, systemic levels of IL-6 was associated with cardiac dysfunction in mice. Okay. Now, they wanted to see if pre-treating with intratracheal budesonide, formoterol, or a combination of these two, which is basically Symbicort, would alleviate the systemic IL-6 response and would alleviate the cardiac dysfunction. So they took wild-type mice and IL-6 deficient mice. They were pre-treated with intratracheal budesonide, formoterol, and combination drugs for 3 hours before they were sprayed with lipopolysaccharide. Now, lipopolysaccharide is a component of gram-negative cell bacteria, and it basically causes endotoxemia and sepsis and inflammation. And if you look at the graph, it looks, 4 hours later, arterial blood from these mice was drawn and the levels of IL-6 was measured. And if you look at the graph, you can see that the levels of IL-6, this is systemic IL-6, was lower. It was significantly lower in the mice that received budesonide, formoterol, and the combination with LPS. Now, when they looked at the levels in BAL, there was actually no significant difference. Now, at 4 hours, they also did an echocardiogram in the mice and looked at and assessed the cardiac output, stroke volume, and ejection fraction. And what they found is that along with a drop in systemic IL-6, they also noticed that the mice that received Symbicort or budesonide and formoterol actually had a better cardiac output, had a better stroke volume, and a higher ejection fraction. And the effect was seen with the individual drugs as well as compared to not receiving any drugs. They didn't necessarily give a clear explanation as to why this effect would be seen. Now, we do have to take these results with a little bit of, with a grain of salt, because it's not always that what we see in vitro studies that it gets replicated in clinical studies. And we'll talk about what we know in the clinical setting in a little bit, but just something, I found the paper extremely interesting. Now, lastly, I wanted to talk about ACE2 levels and ACE2 levels in interstitial pulmonary fibrosis. Now, this group looked at ACE2 enzyme activity as well as mRNA expression in lung biopsy specimens of patients with idiopathic pulmonary fibrosis and compared the levels and activity to controls who had non-fibrotic lung biopsies. If you look at the two groups, patients with IPF had a lower DLCO and a higher AA gradient, which is what you would expect. Now, if you look at the graph on the left, ACE2 mRNA expression was reduced by 92% in patients with IPF, and ACE2 enzymatic activity was reduced by 74% in patients with IPF. So it did look like patients with IPF had lower ACE2 activity, and what that may mean in the clinical setting is that they are not at a higher risk for COVID-19 infection or severe outcomes. But we'll talk about that a little bit more. All right, so what do we know about outcomes in patients with underlying disease in the clinical setting? So I'm going to talk about two papers which discuss COVID-19 and asthma. Both of these papers were from the United States. This one is from our colleagues in Colombia. It was a retrospective chart review study, N of 1,298. Patients greater than 65 years and or with a history of COPD were excluded. I think they wanted to make sure that it was a relatively homogeneous cohort. What they found is 163 of 1,298, that is 12.6%, had asthma. The percentage of patients in the pediatric group was much higher as compared to the average or the percentage of patients in the adult group. Now, if you look at the patients with asthma and without asthma, asthmatics were more likely to be females and were more likely to be obese. And if you look at the outcomes, asthma was not associated with significantly longer length of stay, was not associated with a higher rate of readmissions, intubations, need for tracheostomy, or mortality in this particular group. Now, what they also did is they compared the prevalence of asthma in hospitalized COVID-19 patients by zip code to that of the prevalence of asthma in the general population. What they found is in all but one zip code, the prevalence was much higher. The asthma prevalence in COVID-19 patients was much higher than the asthma prevalence in the general population. And this raises the question of, was asthma a risk factor for increased hospitalization? Now, this paper attempts to answer that question. This was from a group in Chicago. It was also a retrospective chart review study where N was 1,526. 14% had asthma. What they found is that asthma was not associated with a higher risk of hospitalization and was also not associated with a higher risk of mortality. Now, there was a multivariate analysis done, and confounders such as age, sex, race, smoking status, and comorbidities was also done. This was because if you look at the patients with asthma, they were more likely to have a lot of other comorbid conditions such as obesity, hypertension, diabetes, CAD, COPD, GERD, and allergic diseases, all of which are known risk factors, are known independent risk factors for COVID-19 unfavorable outcomes. But in spite of the multivariate analysis, there was no association found with hospitalization or mortality. Now, what they also did was they tried to see if pre-admission ICS use, inhaled corticosteroid use, was associated with a higher rate of hospitalization or mortality, and they did not find this association. It wasn't a significant association. It did look like patients who were admitted to the ICU were asthma patients who were admitted to the ICU were the percentage of patients who were using the combination regimen of ICS and LABA was much higher, but the outcomes were not different. Now, I wanted to talk about a couple of UK papers because the results over there were a little bit different than the results in the United States. This is data from a population-based observational community cohort that was set pre-COVID-19. In this paper, the authors tried to assess the risk factors that predict poor outcomes in the pediatric population. So patients less than 60, patients who were over 65 years of age. The sample size was very large. It was 69,000, of which 507, that is 0.2%, were hospitalized, of which 141 or 28% died. So when they looked at predictors of hospitalization, they found that age was a significant predictor. Male sex was a significant predictor. There were racial differences as well. Being illiterate was also a predictor of a higher need for hospitalization. Now, when you look at the comorbidities that predict inpatient hospitalization, the usual ones of atrial fibrillation, hypertension, diabetes, COPD were seen. But interestingly, a prior history of pneumonia, dementia, and depression had a much higher, the patients with these comorbidities had much higher odds of needing inpatient hospitalization. As you can see here, COPD was associated with a higher risk of hospitalization in patients over 65 years of age, but asthma was not. Now, when they looked at predictors of mortality, the same ones of age, sex, ethnicity, and education were again present. COPD was associated with a higher risk of death in this patient population, and asthma was not. And again, the other comorbidities such as atrial fibrillation, diabetes, COPD, depression, dementia, and previous history of pneumonia were associated with hospitalization. When they looked at asthma a little bit closely, it was associated with a higher risk of hospitalization in women, but it wasn't associated with a higher risk of mortality in them. Now, the same group analyzed all the patients in the UK Biobank community cohort, that is N of 492,000, to look at the outcomes of COVID-19 in asthma patients. And they stratified asthma patients into several asthma phenotypes. Now, 14% of this entire cohort had asthma, and 641 of them had severe COVID-19. And if you see, overall, in the asthma, in the asthma patients, the mortality was significantly. No, the presence of severe COVID-19 was significantly higher as compared to those who did not have asthma. This was also observed in patients with non-allergic asthma, asthma with COPD, and asthma without COPD. The only group that did not have a significant association with severe COVID-19 was actually patients with allergic asthma. The p-value of this association was not significant. So this raises a lot of questions. What we are seeing in our cohorts, is it because it's a very heterogeneous group of asthma patients? Is the protective effect of allergic asthma neutralizing the poor outcomes in other phenotypes of asthma? We don't know. I think we don't have any studies in the United States that have looked at this very closely, but it's definitely something to watch out for. Now, what do we know about COVID-19 and COPD? This was a meta-analysis combining data from 21 studies. The N was 4,603. And what they found is COPD was independently associated with a higher mortality, with odds ratios of 4.36, was associated with severe COVID-19, with, again, odds ratios of 4.62, with need for ICU care, with evidence of disease progression, as well as the composite score. Now, when they stratified the patients based on smoking history in this meta-analysis, they found that current smokers had a higher risk of composite endpoint, but they did not have a higher risk for mortality, ICU care, or disease progression. They also had a higher risk for severe COVID-19 with an odds ratio of 1.65. So what about COVID-19 and ILD? We have two papers, and the sample size in both of them is very low. This one is from China, where they looked at 28 patients who had a diagnosis of ILD among 3,201 cases, COVID-19 cases. And the prevalence was 0.88, which was much lower than the prevalence in the general population, which again raised the question of, are these patients at a lower risk for COVID-19, or are they just being more careful and quarantining and maintaining social distance, that they have not been exposed and been diagnosed with COVID-19. This was a case-controlled study, and 1-to-4 matching was done for age, sex, and severity. And what they found is patients with COVID-19 and ILD had much higher levels of markers of aggravated inflammatory response and coagulation dysfunction. So much higher levels of neutrophils, TNF-alpha, IL-1 beta, urea D-dimer, and coagulation profiles. And they were associated with poorer outcomes. So if you look at the outcomes, 40% or 39% of patients with ILD had a poorer outcome as compared to 59.4% of patients without ILD. Now, this paper was published by a group at Brigham and Women's. It was a retrospective case-controlled study. The case number was 46, and they did 1-to-2 matching for age, sex, and race, and the controls comprised of 92 subjects. What they found is that patients who had ILD were more likely to be hospitalized, were more likely to need ICU level of care, were less likely to be discharged, specifically discharged to home, and were more likely to die. The odds ratios were 3.2 in this group. They did a multivariate analysis and controlled for comorbidities and other confounders, and the odds ratio worsened actually to 4.3, and it was a significant result. Now, when they looked at the patients with interstitial lung disease and COVID-19, and they tried to look for predictors of survival in patients with ILD, all they found was age, that the lower age, the patients who survived were just much younger compared to patients who died. If you look at the analysis further, there was a significant difference in some lab parameters, which again go with the point that ILD patients who were admitted with COVID-19 had a profile suggestive of aggravated inflammatory response, which have been associated with poor outcomes irrespective of risk factor, just in general, COVID-19 patients. Now let's talk about readmissions in COVID-19. I have two papers that I wanted to talk about. This one is a retrospective nested case control study where one-to-one matching for age, sex, and period of admission was done. And they found that of the 1,368 patients who were discharged from the hospital, 61 were readmitted. Now, if you look at the characteristics of patients who were readmitted and compared them to controls, the readmitted patients had a shorter duration of hospital stay, were more likely to have a fever within 48 hours of discharge, had a shorter duration of afebrile period while hospitalized. But the oxygen saturations at the time of discharge didn't actually significantly differ between the two groups. Now, when they looked at the reasons for hospital readmission, pneumonia was the most common. 55% were readmitted because of this bacterial infection. And interestingly, 13% were readmitted because of pulmonary thromboembolism. And there were two more patients who actually had DVT and arterial thrombosis. So 10 out of the 61 patients were readmitted because of venous or arterial thromboembolism. This is a case series that was published by a group at NYU. It's a case series comprised of 9 patients who were readmitted to the hospital for concerns of venous thromboembolism. The patients tended to be on the older side. They were more likely to be men. The duration of stay at the index hospitalization was between 1 to 4 days. So it was a relative 1 to 7 days. The average C-reactive protein level was 100 and D-dimer was 400. The days between admissions ranged from 1 to 8. All the patients had higher levels of CRP and D-dimer at the time of readmission. They were readmitted primarily for either an NSTEMI, a new right bundle branch block, stroke, or bilateral lower extremity DVTs. And if you look at the cause of death, it was either because of ARDS or cardiogenic shock or regular shock. Now, this raises the question of whether these patients, is there a concern for persistent systemic inflammation or coagulation dysfunction in patients? Even if the patients have improved symptomatically and hypoxia is better, is there a possibility that there is persistence of the coagulation dysfunction that results in development of a VTE? Lastly, let's talk about post-COVID-19 syndrome. This paper was published by a group in Italy. It was a prospective observational cohort study, N of 143. It's important to know that 22 patients were excluded from the analysis because they had persistent SARS-CoV swab. And we don't know how that may or may not impact the results of the study. Follow-up was at a mean of 36 days from discharge. 79 of the 143 patients, that is 55%, reported greater than 3 symptoms about 5 weeks post-hospitalization. Now, if you look at the characteristics of this group, 72% were diagnosed with a pneumonia, 13% required an ICU admission, 14.7% had non-invasive ventilation, need non-invasive ventilation. The median duration of hospitalization was about 13 days. Days since discharge, as I mentioned, was 36. 55% had greater than 3 symptoms, and 44% complained of worsened quality of life since diagnosis of COVID-19. Now, when you look at the symptoms that the patients present with, the most common symptoms appear to be fatigue, dyspnea, and joint pain, and much lower down, we have cough, anosmia, rhinitis, etc. Now, what do we know about radiographic progression in hospitalized COVID-19 patients? And this was a paper where they looked at progression of CT scans in 4 weeks of hospitalization. They included 17 patients who had 4 CT scans in the month that they were hospitalized. At week 1, when the symptoms were getting worse, what they noticed was that there was a higher prevalence of bilateral infiltrates, peripheral infiltrates, and subpleural infiltrates, or subpleural and peribronchovascular infiltrates. As the symptoms worsened, at week 2, they found that the CT scan also showed worsening infiltrates. The peak CT scan findings were at week 2 since symptom onset. And what they found is 76.5% of patients had crazy paving, 64% had air bronchograms, and 76% had thickening of adjacent pleura. 47% also had enlarged pulmonary vessels. Majority of the patients also peaked with your symptoms at this point. Now, as symptoms got better, the CT scans also got better, but there was a lag. A lot of patients didn't have any symptoms at week 4, but there were persistent findings on the CT scan. This is not surprising because even with regular pneumonia, there's always a lag in improvement in chest x-rays compared to patients' symptoms and clinical presentation. So at week 4, what did they find? They found that 10 of the 17 patients had evidence of enlarged pulmonary vessels. They also found that 3 had evidence of pulmonary fibrosis, and 2 had evidence of bronchular dilatation or bronchiectasis. So 5 of the 17 patients had findings that could potentially be more permanent. Now let's look at CT findings post-discharge. Now this was another retrospective chart review study where N is equal to 32. COVID-19 patients who had 2 in-hospital CT scans and 1 post-discharge CT thorax was included in the analysis. The median duration to last CT thorax was 9 days, and 44% had evidence of fibrosis. And when they compared the group that had fibrosis to the group that didn't have fibrosis, age was the only risk factor that they could identify. In addition to diabetes, hypertension, cardiac disease, all parameters of severe COVID-19 were also associated with fibrosis. A longer length of stay in the hospital and ICU admission was also associated with fibrosis. When you look at PFT abnormalities, this was a paper where they actually they did PFTs in patients without critical illness at the time of hospital discharge. And what they found is about 47% overall had an abnormal DLCO, and the percentage of abnormality increased with the severity of COVID-19. Similarly, there were abnormal TLC abnormalities, which is suggestive of restrictive lung disease. In the overall cohort, it was 25, and in patients with severe pneumonia, it was 47%. This was a case series that was published out of University of Virginia. In the interest of time, I'm just going to skip to the next slide, where it was the number of patients included in this analysis was 26, and 38% of patients had abnormal lung function, 15% had obstruction, 19% had restriction, and 26% had reduced DLCO. Now, these patients were followed up on an average of 39 days post-hospital discharge. And lastly, this paper showed that D-dimer D-dimer at the time of hospitalization could be a predictor of persistent symptoms and abnormal CT scans at the 3-month follow-up, which raises the question of whether microthrombi, pulmonary hypertension, etc., plays a role in the persistence of symptoms. In SARS, it looked like as time, this is from the original SARS epidemic, it looked like as time progressed, the percentage of patients with abnormal DLCO actually increased. So at 12 months, 23% had abnormal DLCOs and 27% had abnormal chest x-rays. Very similarly, in the MERS cohort, 33% had abnormal chest x-rays with evidence of lung fibrosis. And the factors that were connected with lung fibrosis were very similar: age, longer duration of ventilation, more severe chest x-ray findings were all associated with fibrosis. So in summary, ACE2 receptors and type 2 transmembrane serine protease levels play an important role in the pathophysiology of SARS-CoV-2. While COVID-19, pneumonia, and ARDS are well recognized, there are other manifestations in the lungs as well. Low tidal volume ventilation, that is 4 to 8 cc's per kg ideal body weight, is lung protective. Optimal PEEP and optimal method of PEEP titration is unclear for ARDS management. ACE2 expression in the lungs may explain COVID-19 risk and outcomes in patients with underlying lung diseases. Readmission rates are approximately 4.4% at this time. Bacterial infections and VTE seems to play a major role, and 30% of hospitalized COVID-19 patients may have persistent fibrosis, and about 50% of patients still have persistent symptoms 3 months after hospital discharge. That's all I have. I couldn't resist putting these images up. This was published just last week in New England Journal of Medicine, electron micrograph photographs of SARS-CoV-2 infecting the human bronchial epithelial cells. You can see the cilia. You can see the sheer density of virions, and the image on the right is a high magnification image, and you can clearly appreciate the structure of the virus as well as how dense and the sheer number of virions that are present in the airways.